right, so I did not have the foresight to put my email address, but if any of you have pathology questions, I am Maggie S, as in Sam, Ryan at Gmail. So you are welcome to send me a question and I'll do my best to find an answer. So, press the magic button, the off button. All right. So I'm going to talk about neuroendocrine lung pathology, how we get to that diagnosis, how we classify lung pathology tumors with neuroendocrine features. All right, so the first slide, neuroendocrine, this is a sort of strange word in itself. It's sort of a combination of two words. And so what makes a tumor neuroendocrine? Any tumor neuroendocrine, whether that's in the lung, in the GI tract, in the pancreas. So it's sort of a combination of the words neuro and endocrine. So neuro comes from its ultrastructural similarity to neurons. Ultrastructural meaning under the electron microscope, so at a really, really, really high magnification. So quote unquote neuroendocrine cells store these secretory products in granules. And the granules resemble the synaptic vesicles that are seen in neurons. And so probably long ago, someone saw a neuroendocrine tumor cell and said, hey, this looks like a neuron that I've also studied under the electron microscope. And so I think these are related. But neuroendocrine cells are definitively not neurons. They differ from them in that they do not have any processes, and they also have a different secretory mode, which from a patient standpoint, and really even from a pathologist standpoint, is not all that important. It's just good to know that they are different. So just here on the left, this is paracrine secretion, and just shows how that process works, versus neurons that have a synaptic mode of transmission. So it's just, they look like neurons, they resemble them, sort of like horses and zebras are resembling of each other, right? But when you look up close, they're really not the same thing. And then the second part of neuroendocrine is endocrine, and that has to do with the secretory quality of neuroendocrine tumor cells. So not as much in the lungs, although some lung carcinoids or lung neuroendocrine tumors do secrete hormones, but certainly in the gastrointestinal tract, pancreas, oftentimes these tumor cells do have secretory functions. And so that's where the term neuroendocrine comes from, is because of these various features of the tumor cells. But from a more practical standpoint, these are, we define neuroendocrine tumor cells based on similar morphology and similar expression of quote-unquote neuroendocrine markers. So they possess neurosecretory granules that are similar to neurons, but they're not neurons. At one point, people thought maybe they were derived from the neural crest embryologically. That is probably not entirely true. So again, just from a practical standpoint, these are all tumors that share similar features under the microscope, and then that express certain stains and markers that we'll get to. So these tumors, again, whether they are in the lung, GI tract, pancreas, et cetera, they share similar characteristics. And so we're going to go through those similar characteristics that we see under the microscope that help us get to the diagnosis of neuroendocrine carcinoma, and then we further subclassify it. So we look at the morphology, just basically what it looks like under low power, under the microscope, and then under high power as well under the microscope, what it looks like. What immunohistochemical stains do we use to characterize the tumor cells, and why do we use those? The electron microscopic findings, and then they do have some similar molecular properties as well that are an active part of research. So architecture. So these are two pictures of neuroendocrine tumors. They could be from any part of the body. They have an organoid pattern of growth. They form nests and ribbons. So it's really a quite beautiful tumor under the microscope. So under the microscope, you can see it looks like ribbons, and it can form little rosettes, meaning clusters of cells that form around a lumen. And so this is a very characteristic feature. This would be on very low power. Like first, when we put it under the microscope, this is the picture that we see. And this is in direct contrast to the two other main types of lung cancer that we've kind of brushed upon. So adenocarcinoma and squamous cell carcinoma. So adenocarcinoma forms glands and mucin. So if we saw this under the microscope, neuroendocrine carcinoma would not really come into our differentials. It wouldn't be high on the list. As you can see, it's forming glands and the reactive stroma around it. The squamous cell carcinoma here forms keratin. And so these are just differentiating features that we see when we look under the microscope. So on high power, this is the buzzword in pathology for neuroendocrine cells. They have a salt and pepper chromatin appearance. So these nuclei, all of these little round circles, you can see the chromatin inside of them is speckled. So that's very characteristic when we start to see speckled chromatin as opposed to when the nucleus all looks the same, when it's all blurred out together, or you don't see that speckling. Neuroendocrine is less on the differential. So this is a very characteristic feature and one that we look for, especially in the well-differentiated tumors. You'll see that salt and pepper chromatin. So other features that we look for to determine neuroendocrine pathology or neuroendocrine tumor origin, we look at the individual cells, and you can see that the cells have very smooth nuclear contours, meaning they're not very irregular. They're, all of these cells are about the same size. They have somewhat of a streaming quality to them, where they're sort of following in line with each other. And again, each nucleus is about the same size as the next one, and those nuclei are very smooth. They don't have like a raisonoid appearance or irregularity to them. So once we've sort of gotten to, okay, I think this tumor is probably neuroendocrine. It has this organoid nesting pattern. It has rosetting. It's not, especially in a low-grade tumor, it doesn't have a lot of nuclear irregularity. There's that salt and pepper chromatin. We still need to confirm that it is of neuroendocrine origin. So just that first subset of features that I described is not enough to say this is a neuroendocrine tumor. We may say preliminarily, I think this is neuroendocrine, but we have to do immunohistochemical markers to confirm that because those are not definitive features. So synaptophysin and chromogranin, these are our two main stains that we want to use. They're the most specific, meaning they don't really stain other tumors. So sensitive markers will stain the majority of the tumors, but they also may stain other types of tumors. So they may stain an adenocarcinoma. But synaptophysin and chromogranin are really pretty specific for neuroendocrine tumors. And that's because they mark those neurosecretory granules. And so positive staining is in the cytoplasm. So you can see that light blue. These are the nuclei. So those are not staining. But the cytoplasm is staining. It's staining brown for both synaptophysin and chromogranin. And so that is picking up the neurosecretory granules that define what a neuroendocrine tumor really is, the makeup of those cells. So these are both used together. So some tumors stain more preferentially for synaptophysin, some stain more preferentially for chromogranin. Before we stain the tumors, we don't know which one is going to stain, so we always use them basically together. And sometimes both of them will be positive and sometimes just one will be. But having one is really enough to make the call, especially if the other features are there. So CD56, this is our most sensitive neuroendocrine marker, meaning that even more poorly differentiated tumors will still stain for CD56. But it's not specific. It is also present in other neuroendocrine tumors. So I've certainly seen reports that have been generated where a CD56 positive tumor has been called neuroendocrine carcinoma, but synaptophysin and chromogranin are both negative. So, and it turns out to actually not be a neuroendocrine tumor because it can kind of snafu you in that ovarian tumors that have no neuroendocrine features can still stain for CD56. But this tumor marker can be especially helpful, especially in higher grade tumors, because as tumors become more high grade, they lose some of those neurosecretory granules that you see on electron microscopy. And so as less and less of those markers, or as less and less of those granules are present within the cytoplasm, the chromogranin and synaptophysin may not pick up the staining. And so CD56 can be a nice, well, I include it in all of my panels. So I always use CD56 because it can help, especially in less differentiated tumors. And then another stain that we have in our pocket is just a cytokeratin stain. So cytokeratin is a marker of epithelial origin. So it also labels adenocarcinomas that are of epithelial origin. But the pretty cool thing about cytokeratin stains in neuroendocrine tumors is that it gives a characteristic staining pattern around the nuclei. So you can see here on top, this is a neuroendocrine tumor, and there are blue nuclei, and surrounding that, you can see there's dot-like positivity around the nucleus. So this is a different kind of staining. This is just actually a benign gland. But you can see these are epithelial cells that do stain positively, but you can see that that staining is membranous. It's around the entirety of the nucleus, and it's strong and brown. And so this, again, especially in less differentiated tumors, can just be a nice hint that you're looking at a neuroendocrine tumor because of that characteristic staining that we see. So there's not one single stain that is perfect. It is, again, a combination of, does it look like a neuroendocrine tumor morphologically? Does it have the cytology, meaning that salt and pepper chromatin, the nuclear contours? And then we use stains to better characterize the tumor to get to the diagnosis. There are other stains that other institutions use and that we use sometimes as well. These are probably the most common, but if you've seen other stains on your pathology reports, there are a lot of different stains that can be used as well. But these are the most common. And so we kind of talked a little bit about the ultrastructural findings or electron microscopic findings in neuroendocrine tumors. And this is what I'm talking about. So this is at very, very high power. This is a nucleus here. And then this is the cell membrane. And here in the cytoplasm, you can see these black granules that on high power look like that. So you might wonder, well, why don't we, if this is the defining feature of a neuroendocrine tumor, why don't we use electron microscopy all the time? So number one, the number of cells that you can look at under the electron microscope is very small because of the huge magnification that we're using to look under the electron microscope. You can look at 5 to 10 cells, as opposed to looking under the microscope, we're looking at thousands of cells. And so we can get a better idea of, maybe one cell only has a few neurosecretory granules, but another cell adjacent has 100, so that stain will pick up those neurosecretory granules. And also, on well-differentiated tumors, our immunohistochemical stains work great, and the morphology is usually pretty clear. Also, the low-grade tumors have the most neurosecretory granules. So electron microscopy is a pretty large expense. Electron microscopy costs a lot of money. It takes a lot of specialty to look at the cells, and the well-differentiated tumors that have the most granules are not that diagnostically challenging with immunohistochemistry and a regular light microscope. The high-grade, poorly differentiated tumors are not as likely to have the neurosecretory granules under the electron microscope for us to make the diagnosis. So it's not used very often in modern path. So we're here today to talk about neuroendocrine tumors of the lung. So the same principles will apply to each of these tumors that I'm going to discuss, all the neuroendocrine tumors, and then I will discuss how we get to each of the different classifications. So this is a picture of normal-ish lung tissue. There is no tumor here. So this is an artery. You can see here the alveolar septa. They're one cell layer thick to allow blood and gases to be exchanged. And you've got a bronchiole down here. So this is just a normal lung. So pulmonary neuroendocrine tumors, as we've kind of heard over and over, the classification that is provided by the WHO starts with typical carcinoids, atypical carcinoids, large cell neuroendocrine carcinoma, small cell carcinoma that we break down a little bit, as well as non-small cell carcinomas with neuroendocrine features, basically meaning that we detect neuroendocrine features only by using those special stains or by electron microscopy. So all of these tumors have some things in common. They have similar morphologic features that we have discussed. They have similar immunohistochemical features. They differ in a number of ways that we've seen in a variety of graphs. The two main ways that they differ, as we've also discussed previously, is based on mitotic activity, whether that is a count of mitotic figures per 10 high power fields, or Ki-67 proliferative indexes, and necrosis. So those are the things that we are mainly looking at under the microscope, is once we've determined that yes, it's neuroendocrine, then we want to know, okay, how much mitotic activity is there? Is there necrosis? So we sample these tumors. We don't just take one section of the tumor and come up with the diagnosis. We have to sample these tumors really extensively to make sure that we've looked for the most mitotically active area and whether or not any necrosis is present so that we can best classify them. So carcinoid tumor or well-differentiated neuroendocrine carcinoma. So there is a sort of a movement in pathology and other literatures to move away from words like carcinoid tumor that sounds very benign and move it into calling all of these carcinomas well-differentiated, intermediate, and poorly differentiated. So I will kind of refer back and forth to these. So this is a carcinoid tumor. This is a lung that has a tumor in it. So this is the lung that's been bivalved, so it's been cut in half, and you can see this tumor is just popping out, which is a very characteristic appearance of what these tumors look like. They have a kind of bulging appearance. They're smooth and kind of fleshy appearing. So in the lung, these tumors derive from neuroendocrine cells that exist normally in the airways. The Kolchitsky cells, these tumors in the past have been called Kolchitsky cell tumors. They've had a variety of different names. They've been called benign carcinoid tumors, which for clear reasons we do not want to see or report them as such. So the diagnostic criteria, we look at these tumors under the microscope and we count 10 high power fields. So we look for the areas that are most mitotically active. So if we see an area just sort of scanning around that has a number of mitotic figures, we want to go on high power, so we put it on the highest power of our microscope at 40x, and we count 10 consecutive fields and see how many mitotic figures we can count. So less than 2 mitotic figures per 10 high power field. So basically you get 0 to 1 in order to have a well-differentiated neuroendocrine carcinoma. And there cannot be any necrosis, and the tumor must be 0.5 centimeters or larger. Smaller than that, and it's considered hyperplasia and not necessarily a malignant process. So again, we look at this, and on low power, it's bland and it's monotonous. You're not going to see a lot of atypia under the microscope. It will have that typical organoid neuroendocrine growth pattern that all of these tumors have. And there's some fibrovascular septae that separate the tumors. So some things to keep in mind and why there's a push to start maybe moving towards calling these well-differentiated neuroendocrine carcinomas as opposed to a carcinoid tumor is that they are not an entirely benign tumor. Certainly a diagnosis of benign carcinoid tumor is not favored or very common anymore, but it certainly still does appear occasionally on pathology reports. So these can metastasize, and while they do have excellent 5-year survival, it is not 100% necessarily, and so they are a malignant tumor, and they can be fatal and can usually be cured by surgery. So then we move on to atypical carcinoids, and these differ from carcinoid tumors by having increased mitotic activity, meaning 2 to 10 mitotic figures per 10 high power field, or they have foci of necrosis. So these are in the intermediate grade or intermediately differentiated neuroendocrine carcinomas. So this is one of my favorite pictures that I have ever been so lucky to see. This is an electron microscopic picture. It's actually a renal tubule, so it's not actually in a lung tumor. But this is a mitotic figure, and since that's the defining feature, basically, of getting to atypical carcinoid from typical carcinoid, so this is the metaphase, and this is the spindle. This happens in like a millionth of a breath of a second, and it happened to be captured in that picture. So I think that's one of the most beautiful pictures of a mitotic figure. We got this in our lab. We got this in our lab one day, and our lab like erupted with excitement when this picture came up. So thank you for letting me share it. So features with atypical carcinoids or an intermediately differentiated neuroendocrine carcinoma, features that may portend a worse prognosis are stage, and this is probably the most important Factor stage is based on a number of features that I'll get into a little bit later. It includes lymph node metastasis, the size of the tumor. Larger tumor size does portend a worse prognosis. The mitotic rate, so if you have maybe 2 mitotic figures versus 10 mitotic figures, it all falls in that same category, but there may be a difference. Cellular atypia, where the cells have variation in size and shape. How much necrosis there is there just one or 2 cells that are individually necrotic, or is there a larger area? And if there's vascular invasion. And so I have circled here, this was an atypical carcinoid. It was diagnosed with 4 mitotic figures per 10 high power fields. So, again, we counted 10 consecutive fields and found 4, and so it falls into that category. And that circle there is a mitotic figure under the microscope. I guess now is probably not a bad time to discuss that, mitotic figures can be challenging to see under the microscope. I'm sure some of you are going, yeah, sure, I believe you, that's a mitotic figure, but it could just be like a blobby nucleus. And so that is why we do use Ki-67 proliferative indexes as well. It's a more sensitive, a better way to see cells that are undergoing proliferation. In lung tumors, it is not currently being used in the WHO criteria. That being said, in our institution, we do a Ki-67 on any of these tumors. We incorporate it into the report, and then that is used by the oncologists and surgeons for treatment, or at least so that down the road, if it becomes incorporated into the WHO criteria, we have all that information on tumors that are coming through. But we do mitotic counts. That's what the criteria are at this point. So this is has a distinctively more aggressive clinical course than typical carcinoid or the well-differentiated tumor. The survivals are lower than typical carcinoid, and so it is certainly important to know the mitotic count to know if there's necrosis. Again, that's why we sample these tumors so extensively and look at multiple sections under the microscope to make sure that we are capturing the appropriate classification of the tumor. Because they can look on low power, these also look like a carcinoid tumor, which is probably where this typical/atypical comes from. You'll see in the next few slides that the higher grade tumors have a different appearance than these carcinoids. But on low power, an atypical carcinoid and a typical carcinoid look very, very similar. And it comes down to high power view of mitotic counts and whether or not there's single cell necrosis. So large cell neuroendocrine carcinoma, this is the start of the moving into the higher grade neuroendocrine carcinomas. This is a high grade neuroendocrine carcinoma, behaves very similarly to small cell neuroendocrine carcinoma. So it has neuroendocrine morphology, but it may be more patchy in appearance, or it may just be that there's that salt and pepper chromatin that sort of alludes us to the fact that we're looking at a neuroendocrine tumor. It has a much higher mitotic rate. It has to have 11 or greater mitotic figures per 10 high power fields, but usually we're talking about 50 mitotic figures per 10 high power fields. So usually it's not on the border of 10, 11, where you're wondering if you're looking at a high grade tumor. The mitotic count is usually very, very high in these. And they have large zones of necrosis. So this is a picture of just necrotic tumor, really. The blue cells here are nuclei that are holding on for dear life, but they're in the process of dying. And over here, this is sheets of necrosis. So this amount of necrosis and this amount of death is not something that you would see in either typical or atypical carcinoids. Once you have this sheet-like necrosis, you're dealing with something that is much more high grade, and depending on what it looks like morphologically, you're dealing with a small cell versus large cell neuroendocrine carcinoma. So it has non-small cell features. And by non-small cell, it means that there's a lot of cytoplasm. So small cell carcinomas have very little cytoplasm. That's where they get this distinction of small. These have prominent nucleoli that you can see. So within the nucleus, you can see a punctate dot. And the low nuclear cytoplasmic ratio is just that there's a lot of cytoplasm in these cells. But they do stain positively for at least one of the neuroendocrine markers. They may not, like the well-differentiated tumors may stain for all of the neuroendocrine markers. These are less likely to stain for all of them, but they will have staining for at least one of the neuroendocrine markers in order to call it a neuroendocrine tumor. Or you'll have neuroendocrine granules on EM, but again, that's not used too often in practice. So these are an unquestionably high-grade tumor, and they behave a lot more similarly to small cell carcinoma than they do to typical or atypical carcinoids. So they're certainly in the high-grade category of neuroendocrine tumors. So small cell carcinoma, the last of the four main categories. So these are sheets of cells. They have a very high nuclear to cytoplasmic ratio. As you can see here in these tumor cells, all you really see is blue. So then you can just see the nuclei. They're molding to each other, meaning they're pushing into each other and molding. So that's a very characteristic feature. And they have very dense cytoplasm. So you can see that dense blue cytoplasm. That's not because this particular slide was overstained or stained differently than any of the previous slides. That's just a characteristic of this tumor that chromatin is really, really dense. And so these will have extensive necrosis, similar to that picture that I showed you before of just sheets of necrosis. Another characteristic feature that we see with small cell carcinomas is crush artifacts. So these cells are very fragile, and you see these cells that are streaking out and are crushed and broken. So when we see this if I get this slide or any pathologist really gets a slide that has this much crush artifact, our main differential is small cell carcinoma or a lymphoma. So lymphomas can also do that. Some would advocate that when you get something like this that looks so characteristically like a small cell carcinoma, that if you just do an epithelial marker, so a cytokeratin stain, and a CD45, which marks lymphocytes, if it's cytokeratin positive, it's a small cell carcinoma. These will have a lot less of those neurosecretory granules, so sometimes the neuroendocrine markers won't even really be helpful. And the main thing is just knowing that you're not dealing with a lymphoma, because the treatments are extremely different for those two tumors. And we do need stains to differentiate them almost 100% of the time. So if you ever hear that you're waiting for stains from pathology, sometimes it's ruling out lymphoma versus a carcinoma, and so certainly getting to the right answer is important because the treatments are so different. So small cell carcinoma is often with widespread disease at the time of diagnosis, and it is staged accordingly, as was discussed a little bit previously. So you can have limited versus extensive disease, and so that's how we stage that. So basically it's either restricted to one hemithorax, only in certain lymph nodes, or if there's a pleural effusion just on the same side of the tumor. Anything other than that is considered extensive disease, and the prognosis changes dramatically. And then this is just to kind of a recapitulation of what I've already discussed. These high-grade tumors can lose immunohistochemical staining, and so we need to incorporate the morphology as well as the positive stains that we do have in order to get to the diagnosis. We have the worst prognosis among the neuroendocrine lung tumors. They have 5-year survival is pretty low, and that's with limited disease. With extensive disease, it's certainly worse. Extensive disease, stage of disease, poor performance status, as well as some laboratory features give it a worse prognostic implications. So then the other reason we sample these tumors really well, and that's to make sure that there may be a small cell component to the tumor, but there's also other areas that look like adenocarcinoma. There are other areas that look like squamous cell carcinoma. So we can have combined small cell, large cell neuroendocrine tumors, and we just specify which type of non-small cell carcinoma is present and how much of each. And that may change therapeutic options for the patient. And then there's this one, which is always a challenge. So basically it's a tumor that doesn't necessarily look like a neuroendocrine tumor, but we've run neuroendocrine tumor markers on it, probably to work up what kind of a tumor it is. It turns out that it has staining properties that are similar to neuroendocrine tumors. And so we will describe that it's an adenocarcinoma with neuroendocrine features. And there's still a lot more work that needs to be done in this area to determine what the implications of that is. And so in the end, after we have determined the diagnosis, which is a neuroendocrine tumor. Then we determine the grade, and that grade is based on mitotic activity, necrosis, and vascular invasion. And then we provide a stage, and that involves whether or not the tumor invades the pleura, how big the tumor is, whether it invades a bronchus, if there's a collapse of the lung, lymph node involvement, invasion of any surrounding organs. So all of those items go into the pathologic stage of the tumor, which we provide in our report, and that is given, we have a book of tumor staging and grading that we put all of the characteristics of the tumor into, and then can issue a stage based on that. And there are all of the morphologies of the varying neuroendocrine tumors of the lung.